Professor Sir Malcolm Grant, Chair of NHS England. Malcolm.
Well, thank you very much, John, and I'm delighted to have the opportunity and very honoured to be invited as a humble lawyer. Well, scratch humble, but in this august scientific company. But I've listened so carefully to both Nancy and Patrick and in my mind mapped everything they've said upon the way in which we at NHS England are thinking about 2025. It's unusual within the NHS to have this capacity because of the way in which the service since 1948 has so strongly been dominated by short-term politics. I don't anticipate that the desire to do that will diminish over time. But the capacity now in England of having established an independent board with a majority of non-executive directors and controlling a budget of approaching £100 billion per annum, with a mandate requirement imposed by the government in an open public document laid before Parliament, a mandate to improve the health outcomes for the population of England, and a mandate which ideally, though not yet in practice, focuses on outcomes rather than on process, provides us, I think at last, with at least the mechanism to try to transcend political timelines and to look at 2025. Let me stress that what I'm going to talk about this afternoon relates to England. There is a devolved health administration in both Scotland and Wales, and so forgive me if my comments are England-focused. I need to start by impressing upon us all the sheer complexity and range of what the NHS does in England. We calculate that there are 1 million patient consultations a day in the NHS. There are every year 458 million visits to community pharmacy related to NHS business on top of that. We have 19 million emergency ambulance journeys every year, and we have 21.7 million attendances at A&E. The second part of the complexity is the workforce. It's commonly understood that the NHS employs 1.3 million people in England, but that's only part of it. Alongside that is another 1.5 million people employed in community social services. Alongside that, another 5 million people who provide care for family or loved ones. Sorry, those aren't two separate categories, well, not always. Alongside all of that, we have calculated that patients themselves engage in 5,000 hours of self-care for every 1 hour of contact with the NHS. And if you start to look at the organisation in these terms, it starts to change the way in which we think about the delivery of care in the NHS. And in thinking about that, I'm very taken by an approach which has been adopted in that pioneering country, New Zealand, where in Christchurch, following the earthquake 2 years ago, they faced a shortage of acute beds, and they asked themselves, what is the most important asset in a healthcare system around which everything should be framed? And the answer was the time of the patient's time. And that, I think, is a very useful intellectual starting point for us to understand how we move from a model which has been traditionally framed by those who provide healthcare to one which is framed around those who receive healthcare. And let me set out why it is that we face an urgency to attend to these issues. And then I want to sketch out the 6 key characteristics that we at NHS England have devised in our own thinking about what 2019 should look like, let alone 2025. The starting point is the financial state of the national economy. Every year since 1948, expenditure on the NHS has risen by 4% real. In other words, 4% above inflation. Demand for the NHS services has been rising at roughly the same rate, and there has been a rough matching over time. We now spend twice the proportion of GDP on the NHS that we did in 1948. However, since 2011, investment in the NHS has been frozen at flat reel, with some marginal adjustments. Indeed, with some adjustments that may reduce that because of some transfers out of mainstream NHS funding and into social care, for good reason, which I'll return to in a moment. However, the demand side has not subsided. Demand continues to rise at the same rate, and with an ageing population, we anticipate that it will continue to rise at that rate, if not at a greater rate. The reason for that is that although longevity has been a spectacular success, not only in England but in the developed world, the years of healthy living have not expanded at the same rate as the years of life, and so people are living longer with one or more long-term conditions requiring management, and management of a different sort from that which historically has been the model for the NHS. So we figure that by 2020, we will in England, out of that £100 billion investment, have a funding gap of £30 billion. We figure that we can deal with probably 30 or 40% of that funding gap through the traditional modalities, through staff pay restraint, through improved procurement, and through other efficiency savings across the NHS. But even if we were able to raise that 30 or 40% to 100%, we would still have a healthcare system that wasn't fit for purpose for the needs of the population in 2020. And so I want us to spend a moment looking at how it is that we need to bring about the reforms that are necessary. But before I do, to explain one thing which is commonly misunderstood about the NHS. It's sometimes assumed, and particularly in the popular press, that the NHS is like a big hospital. There's a chain of command, there's a number of different departments, but they're joined together in some rational and accountable way, and that movements across the system can be readily tracked, and that strategies can be implemented across the board. It's just not true. The NHS is an extraordinary ecosystem, a vital ecosystem, of course, but an ecosystem in which there is a split between commissioners and providers. And on the commissioning side in England, there is now, in addition to ourselves, 211 new clinical commissioning groups to whom we assign £65 billion a year. And they represent populations ranging from about 60,000 through to 900,000. So they are an experiment, a live experiment at the moment, and I can assure you that at their very best, they are going to be game-changing, innovative, exciting, and worth watching. I won't mention what they will be if they're not at their very best, but it raises a fundamental question for us this afternoon, which is how do we replicate innovation? How do we replicate excitement that occurs when clinicians are given their head and allowed to innovate and allowed to change things, and how do we spread that across the rest of the system? But the second part of the fragmentation is not in the commissioning side, but in the provider side. We have some 250 trusts, which are units of organisation of provision, of which about 150 are foundation trusts and the others are aspirant foundation trusts. But alongside them, a model of primary care which comprises 20,000 GPs in England, grouped into 8,000 practices. All of those are small businesses run as independent contractors. It's a fundamental tenet of the NHS that GPs are not employees. They're independent contractors. So our relationship with them is through the GP contract, which we negotiate annually, and through our commissioning arrangements for primary care. So money, incentives, and other ways of challenging behaviour are absolutely essential in the way in which we do things. So with the complexity of that system and with the changes that were brought about in the 2012 legislation, there's actually no top-down model any longer, if there ever was in the NHS. And we know the dangers of top-down models because of Mid Staffordshire. The more there's top-down insistence upon the setting of targets and the attainment of targets, the more the management attention turns to the target and to the process, rather than to the holistic vision of what is best in the interests of patients. So we have to work with a system which is dynamic and which is capable of bringing about change, albeit sometimes far more slowly than we would wish it to do. So we have worked out in our minds what might be the 6 characteristics of a system in 5 to 10 years' time, but not a blueprint for change and not something that we can drive from the centre, because much of this has to be done locally. It's also, I should stress, it's a fixed price menu in two senses. One, there's no more money, and two, each one of these 6 characteristics is interdependent with the others. This isn't a la carte. This is not for picking and choosing. So just to divide them very briefly, there are 2 groups, I would say, in my classification. The first is around care that wraps around patients, and the second is around the future of hospitals. Let me start with care around patients. We start with the first characteristic that picks up much of what Patrick was saying earlier, which is that it is the patient that's at the heart of everything that's done. And that's just not a rhetorically empty phrase. We can foresee that with the advances in technology, the ability for patients to monitor their own health, to look after their own health, to be more involved in the prevention of ill health will be completely enhanced over the next decade. And in a way, the traditional relationship of dependence between patient and professional will change dramatically. Will we even have that long-term continuity of care of a family doctor? Well, I think we will for an older population, but not for a younger population, where the relationship is already a transactional one. We have a significant number of younger people in London, for example, who we know are not registered with a general practice. And in the event of illness, will either have recourse to a company-funded model of access to primary care, or will go to A&E. A&E at least gives a guarantee of being seen within 4 hours. So we know that a large amount of investment up front in enabling patients to take greater care of themselves will pay dividends. We also know that this is true of patients with long-term conditions, and witness the extent to which care for diabetes and other long-term conditions has moved out of hospitals, moved into the community, and moved into the home. So we can understand how that might work. That brings me to the second of our key characteristics, which is a transformation of general practice. We foresee the need to move primary care from being something of a corner shop industry in many parts of the country into being provided with a wider vision, a wider scale, and also at scale. In London, 20% of GP practices are single-handed. I find it difficult to conceive how a single-handed GP in the 21st century can cope with a model of medicine that is both much more effective and much more dangerous than it was 20 years ago. The ability of GPs to come together is now starting to become a movement across the country. At the other end of the scale in London, there's a practice with over 110 doctors working in it, and we are seeing across the country now a coming together of GP practices. I don't care why or how it happens. I don't care. What I'd like to see is a model of alliance or merger or confederation which brings about a sharing of responsibility and an ability to incorporate high-level diagnostics into the practice premises and to bring consultants out of hospital to work in general practice and vice versa. Which brings me to our third characteristic wrapped around the patient, which is a modern model of integrated care. Integrated care has been the mantra for the NHS for at least 20 years. We have seen quite remarkable advances in parts of the country. We've seen very little in other parts of the country. The point of greatest danger for the patient is the handover of care between different providers, particularly when it's not reinforced by an adequate record keeping and transfer of data system. And so a modern model of integrated care ties in well with those other two and will be absolutely essential from 2015 when $2 billion of our budget goes into a joint fund with local government to advance social care. Now, all of this is a mission to take as much care as we can out of hospitals and bring it to the home or as close to the home as we possibly can. Let me then turn to hospitals. The three major points about hospitals, first of all, around accident and emergency, which has become, in some parts of the country, a substitute for primary care. Sometimes seriously misused, but on other occasions, with a clogging up of the service by patients who, had they had proper integrated care, would never have gone near A&E. I'm thinking, for example, of patients with chronic obstructive pulmonary disease who, with a proper model of integrated care led by GPs, with social care and with proper surveillance in the home, will be kept some distance from A&E. A very good report 2 weeks ago from Sir John Oldham, commissioned by the Labour Party, sets this out absolutely brilliantly. And I think there's a strong convergence of opinion as to how we should take this forward. The result then for A&E following Bruce Keogh's review of it is that actually real solid A&E with full clinical backup should probably be found only in between 40 and 70 centres in the country. Others will have an A&E department, but they will have early stage transfer of patients who need potentially to be admitted. If that's the case, then it brings me to the fifth of our principles, which is the role of hospitals in providing elective care. 2 points here briefly. One is that elective care can be much more effectively, safely and satisfactorily provided by a hospital whose beds are not being taken up by unplanned admissions through A&E. So that if we can translate and achieve a difference, a distinction between hospitals providing those two, then that will be advantageous. The second is we have so much to learn from other countries where the productivity of elective care is far ahead of what we've managed to achieve here. The final point is specialised commissioning. We directly in NHS England commission about £12.5 billion of specialised care at some of the leading hospitals across the country. That's in 300 different centres at the moment. We're pretty clear that in many of the conditions that are being treated, there is a strong correlation between the volume of throughput and the quality of outcome. I think everybody in this room knows about the experience with stroke in London, of taking the service out of 30 odd hospitals and concentrating it in 8 hospitals with 24/7 cover, consultant cover, thrombolysis, and with highly trained technical staff. Outcomes go up, lives are saved. So we've indicated we would foresee specialised care being provided in between 30 and 50 centres across England, a significant reduction of where we are today. Now, as I said at the outset, none of this stands alone. All of this is a package, but we have charged the 211 CCGs with the responsibility in their planning now to work out how this would work out in each local health economy in the country. I think that the implications for the discussion this afternoon are quite significant. We can't drive these changes through the NHS in England simply by waving the flag of economic austerity. There is no less convincing argument for the public. What has to be brought, I think, to everybody's attention is that this is about far better care for patients, care delivered at the point of need, care delivered in the home, but above all care that with the innovations that both Patrick and Nancy have spoken of, care that's driven by the patients themselves. I foresee that in 2025, if not before, the new generation of patients who are coming through will be the ones who drive their own care. Enhanced access to information, enhanced access to monitoring, and enhanced access to diagnostics and treatment. Diagnostics will become less expensive for the conventional models. I was in a laboratory in Russia 2 weeks ago and saw the prototype of a device which is about the size of one of Patrick's white pills, which contains in it a tiny camera, a lighting system, a battery and a transmitter, which transmits to a device on the waist of the patient. It's swallowed, and should the battery last long enough, will combine an endoscopy with a colonoscopy without any other invasion and transmitting the pictures back to the device. So I mention that because it's probably old hat to everybody in this room, but for me, a startling example of how a combination of miniaturization and digitization can transform the system. I would, had I had time, talk about care.data. Can I just say there is nothing more important to everything I've just said. The NHS is flying blind. We've got an extraordinary amount of information and data. we've got limited intelligence as to actually what works. We can enhance our ability in this country to improve the health of the population by mining those data that we have and combining it with the big data analysis that will come from genomic sequencing, from metabolomics, indeed from all the omics, where we are able to combine the phenotype of patients with the genotype and for the first time start to understand how the body actually works and how it responds to different interventions. So I can't say that simply having gone to Russia, I have seen the future and it works, but what I can say is this is probably the most exciting and most perilous time for the NHS. It will only, I think, survive as a system free to everybody at the point of need with high quality care if we take responsibility for combining NHS, world-class universities, and world-class life sciences in England. Nobody else can do this, and I do look to the Academy for working very closely with us on the NHS to bring it about. Thank you.